Great. Thank you, Lizzie. Thanks for reminding me. Okay. So yes, for the sake of the recording, just to recap, I'm going to talk about why I think we need a stakeholder-led checklist for mental health data science. I'm going to talk about the Delphi study that we used to develop our checklist. I'm going to introduce the checklist itself, focusing on a few items that I think are interesting to talk about, and pull out some kind of general themes and next steps. And then we will have a panel kind of Q&A session with Mahmud Al-Gailani, who is formerly of Vox Scotland, the primary user-led mental health organisation in Scotland. Matthew Iveson, who is a mental health data scientist, and Lizzy Kirkham, who is a neuropsychologist who led most of this work. You'll hear me mention Lizzy a few times. And I am Sue Fletcher-Watson. I'm a professor of developmental psychology at the University of Edinburgh. And while my expertise is not so much in mental health or in data science, it is in participatory working with stakeholder groups. So that's what got me involved in this bit of work. Okay. So, and some labels. Yes, I wanted to just say something about language I'm going to use. I will refer to people with mental illness. When we developed our stakeholder group who helped advise us during this project, one of the things that we talked about was preferred terminology, and there was a kind of consensus in the group that people with mental illness was preferred, rather than sort of more euphemistic terminology. So that's the terminology I'll be using in this talk, but I want to recognize that different people have different preferences, and that's, you know, important to recognize. Okay, so mental health data science is the use of routinely collected health data, things like NHS records, but also kind of large existing cohorts for research purposes. And it's very important because almost a quarter of people in England, for example, have at least one psychiatric disorder. But despite the fact that mental health difficulties are so widespread, mental health research can miss out the people who are most in need of improved treatments, so the people who are experiencing a serious mental illness, a mental health crisis, who perhaps don't have capacity to consent to be involved in research, and also groups with lower educational level, from more deprived backgrounds, in minority and marginalised groups, all of whom participate less in healthcare research. These same groups are also underrepresented in academia, especially in kind of academic leadership. So we also don't get good lived experience perspectives within academic research. Data science offers a way to improve the way in which research captures those kind of minority or marginalized experiences, because if you're using something like NHS records, you're using records from basically everyone across the UK. And so that gives you a way to engage with those kind of groups who might not be coming forward and volunteering to be part of research. So attitudes to data science in the UK, I mean, broadly speaking, are very positive. There are systems in place to facilitate mental health data science, rigorous processes that govern how we access both routine data from public services like the NHS and also research cohort data. Lots of people, this is from a survey that Lizzy led, lots of people support the use of routine and cohort data for mental health research. And there's also similar results from a recent event that we held in Edinburgh that was led by Iona Benj, looking at the attitudes of people who are already enrolled in research cohorts towards kind of data science issues. But it's not always that simple, right? So our survey also shows that there is lower willingness for sharing of data amongst people who have lived experience of mental illness. There's also lower willingness to share data for people who are less satisfied with the healthcare they've received. And there is a non-significant trend towards higher willingness to share data for people with higher educational levels. So there are groups of people who are less keen on data science, and that kind of overlaps with the groups who are marginalised more generally in society, but also who might be particularly at risk of mental illness. And so, we particularly want to engage those groups when we're doing mental health data science. Even in cohort studies, you can go out and try and particularly target these marginalized groups in recruitment, but that is really hard to do. And even if you manage to, dropout tends to be non-random. So people from deprived backgrounds, for example, are more likely to drop out of studies because, of pressure on their resources and difficulty engaging with appointments over time. So the big question is, who are we not hearing from in these conversations around mental health data science, which all seem to be pretty positive and supportive? We've got these 90% of people feeling enthusiastic about sharing mental health data, but that obviously leaves 1 in 10 people who's less keen. And we really want to try and engage with those people or increase those people's trust in the endeavor of mental health data science. So that's really why we need stakeholder-informed guidelines to address this problem that people with lived experience of mental illness are less likely to be willing to share data, and that everyone is less likely to be willing to share mental health data rather than physical health data. There are also previous occasions when attempts to expand dental data science have failed, like the care.data scandal really in the UK. And of course, even a small minority of people with concerns can still present a significant problem. So just because most people think something is a good idea, that doesn't mean you've done all of the engagement and consultation that you really need to do. There are specific issues as well when you're thinking about data science in a mental health context. So we know that mental illness is associated with stigma in a way that many physical illnesses are not, or not to the same degree. Mental health data also incorporates different kinds of data that may be more qualitative, things like therapists' notes, that contain a lot of important information, but are also really hard to anonymize, and people might feel different about sharing that kind of information than they would sharing, the results of a blood test, for example. And there's also, a sort of history of a lack of trust in healthcare providers and satisfaction with healthcare amongst some people with experience of mental illness that we need to take into account. Okay, so hopefully I've convinced you that a stakeholder checklist then would be a really good idea to help guide the way that we do mental health data science from a stakeholder perspective, and ensure that, or maximize the chances that mental health data science feels trustworthy and valid and authentic and considerate of kind of lived experience. So we decided that a Delphi study would be a really good way to develop such a checklist. And this work was led by Dr. Lizzy Kirkham, who you can follow on Twitter at EK Neuro, and who will be part of our panel at the end of the session. So Delphi studies, for anyone who's not familiar, provide a way to systematically distill knowledge from people with expertise. So you're not looking to recruit a large group of people from a kind of diverse backgrounds and with different perspectives. You're looking for a small group of people with really targeted knowledge of the particular thing you're interested in. And originally, Delphi studies were used as a kind of forecasting method, which is where the Delphi name comes from the kind of oracle at Delphi, right? The ancient Greek fortune teller. But it's now widely used in healthcare and also in patient and public involvement studies to capture knowledge from lived experience. Our goals specifically were to generate this checklist of best practice for mental health data science by drawing on the expertise of people who had knowledge of data science and lived experience of mental illness. And in doing so, we wanted to make a concrete contribution to plans to build a mental health data sharing platform in the UK to facilitate data science. So this is just a summary of the experience that our participants had. This is based on the 20 participants who took took part in all 3 rounds of our Delphi study. Initially, we recruited more than this. About 30 took part in the first round, but there was dropout across the rounds. That's very normal, especially when you're working with people who, as you can see here, all of whom had been diagnosed with a mental illness at some time in their life, and many of them considered themselves to have a mental illness at the time of the survey. But in addition, this survey it kicked off in February last year. And so as it went on through March and April, that was just at the beginning of the lockdown measures for the coronavirus pandemic. So there was particular pressure on people at the time. And I think that probably contributed to retention across the rounds. So this is what the initial version of the survey looked like. I was slightly inspired by these old Love Is cartoons. I don't know if anyone else remembers these, but we decided, every sentence should start with this concept: best practice for mental health data science is, and should follow from that by generating a possible statement that might define what that best practice would be. And we organized those statements into categories just for the purposes of sort of helping orient the survey respondents to the topic each time. And in each case, they could respond to the statement on a scale from strongly disagree to strongly agree here at the bottom of the screen. So those initial statements were generated by our research team, but also evaluated by our stakeholder advisory group, which included a number of people with lived experience of mental illness and also people working in third sector organisations. In round 1, there were 63 of the statements. Some were contradicted each other, some were slightly different variants on the same idea or more specific versions of the same idea. We really wanted to present the panel participants with as many different options for them to consider as possible. And they were able to not just rate their agreement with those statements, but also comment on the wording and make suggestions for things that they thought were missing. The analysis of those data focused on the average agreement score, and you can see here on the right-hand side in blue how we discarded or kept items depending on their agreement score. But also we wanted to reduce down the category and start to kind of combine and refine those statements together. And we also decided at that point that we really needed to split our checklist into actions that could be delivered today, immediately, and things that might be ambitious for the future because they required infrastructure or technological innovation that wasn't available. So in subsequent rounds, the same panel of participants were asked to rank the importance of the different statements and suggest edits, and also rate their satisfaction with the checklist as a whole. And so you can see here that the satisfaction after round 2 of the Delphi was pretty good, but there was still 1 or 2 participants who were dissatisfied. But at the end of round 3, everyone felt at least neutral about the checklist, and the vast majority of people were satisfied or very satisfied with the checklist as a whole. And so we took that as kind of permission to publish. It's probably not going to get any better, because if we adapt it towards to kind of make those people who are neutral more satisfied, will probably make some other people who are currently satisfied a bit less satisfied. And that's the point that we thought we had reached after 3 rounds. So let's just introduce the checklist itself. So this is just a screenshot of the checklist. You can download it from our website there at the bottom. As you can see, it's quite long. There are 14 items, and each item has a version for now and a version for in the future. We decided to organize them into categories, really just for ease of use by people, so that they could sort of understand thematically how those 14 items fit together. So we've got 4 security items, 3 anonymity items, 4 transparency items, and 3 community items. And the whole checklist is supported by illustrative case studies that our team and colleagues across the UK have submitted and that are also available on that same website. And they provide examples of how the checklist can be implemented in practice. So they make the kind of abstract recommendations from the checklist a little bit more concrete. As I said, it's divided into two versions, so mental health data science today and best practice for mental health data science in the future. And those changes in the future are based around things like technical innovations that are required to increase security, a transition to greater freedom actually for scientists in terms of how they deal with anonymity and confidentiality, based on a kind of training and oversight model rather than kind of very strict and restrictive rules. Transparency, really, to achieve the kind of transparency goals of the checklist requires some new kind of governance structures to be in place and potentially staffing. And in the community section, I think there's a focus on mental health data sciences being committed to playing a proactive and positive role in the mental health community. So I'm just going to pull out some examples to look at a bit more closely. This is one from the transparency section. Right now, the checklist asks that researchers have a process in place for responding to withdrawal requests, and that they provide transparency on whether, how, and when participants can withdraw their data. But in the future, the stakeholders that we consulted with were looking to appoint a qualified independent arbiter to arbitrate on complex questions relating to consent and data withdrawal. And so I think what's important here to flag is that, at least as far as our stakeholder experts were concerned, withdrawal doesn't have to be possible for mental health data science to proceed in a kind of ethical manner. But whatever the response is has to be transparent and applied systematically. And so that means that withdrawal processes, including the lack of the opportunity to withdraw data, should be planned in from the start of any new project. And that the best solution for balancing patient and participant rights against scientific endeavour is probably via independent arbitration. Looking at this item from the anonymity section, this is about statistical disclosure control, which currently tends to be based on very strict rules. But the checklist panel were looking to develop a more kind of principle-based statistical disclosure control. So again, what's important here? So for anyone who's not already familiar with the term, statistical disclosure control is about avoiding the chance of re-identifying someone, that should say, due to a rare combination of data points. So even if the data are technically anonymized and you can't tell whose data belongs to who, if someone has a particularly unique combination of characteristics, a particular postcode, a particular ethnicity, a particular kind of lived experience, it might theoretically be possible for them to become identified even when their name and their birth date or whatever aren't in the data set. And so what our panel were looking for was that the basis for statistical disclosure control should be based on a fundamental understanding of the principles that underpin the idea with training and oversight, rather than a set of rigidly applied rules that might sometimes be too strict, might sometimes be not strict enough, depending on the context. So the goal is a transition to kind of greater freedom for researchers based on really profound understanding, rather than this kind of rule-based process. Here's an item from the security section of the checklist, talking about, at the moment, ensuring that data are accessed in safe settings, but in the future, providing more digital control that would allow remote access from private settings. So I think this is really interesting. The current checklist item, I think, is already widespread practice. I would say that anyone doing mental health data science is already using things like safe havens and standard operating procedures to govern how data are accessed. But the panel's goal here was very much about democratization and accessibility of data. So access for people who are home working, perhaps people who might otherwise lack an opportunity to engage with data science, and access potentially for patients and participants in research themselves. I've got a question here as well about potential influence of the survey timing. As I said, we were developing this checklist just at the start of the first lockdown in March 2020, 2019. And so, no, what year is it? 2020. Oh my goodness. Sorry, that's what COVID is doing to my brain. But anyway, the first lockdown was just coming into place. And so I think there was a particular awareness about how home working might be an important part of, the future kind of work environment. And, there was a lot of discussion about how home working was making things more accessible for people with disabilities, for example. And so I think there was a real drive there, potentially among the panel, to think about whether mental health data science could be made more accessible to people outside of the institutions of, higher education. Just a couple more items I wanted to flag. These are both from the community section. So something we really wrestled over was how to talk about the issue of consent within the checklist, because the fact is that for most data science using routine data from things like the census, the National Health Service, birth and death records, people are not giving explicit informed consent for each new analysis of their data. And instead, those data permissions are governed by things like the Public Benefit and Privacy Panel. So we didn't want to specify, and I don't think the panel wanted to specify, that just informed consent was best practice, because it's not really that simple. So instead, we felt that, ensuring that participants have as much control over consent as possible was a reasonable, immediate focus, but that in the future there should be a focus on developing alternative models of consent. So I think the important things to bring out here are, first of all, I think this is a really strong validation of our methods. Our decision to work with experts who had both experience of mental illness and data science meant that they were in a unique position to balance the kind of realistic understanding of what data science, how data science operates, with the kind of lived experience priorities. And that led to a recognition that a kind of blanket model of consent just won't be practical if we want to permit kind of scientific discovery. So what do we mean by individualized or alternative models of consent? Maybe things like consultation with a representative subset of a particular population, who then provide an indication of what would be appropriate on behalf of the broader community that they're a part of. Or maybe in a more focused way, something like a citizens' jury, where people hear evidence from both sides of a debate and then arrive at a kind of conclusion about the best way forward. And those could provide really interesting ways to arbitrate on decisions about how routine data could be used in the future, especially if there's a potential for significant benefit, but also a degree of risk involved. The last item I wanted to pull out just before I start to draw to a close was this second one from the community section, which emphasised the importance that data users understand the underlying tools that we use to collect the data they're working with, and the context in which those studies were designed and the findings were disseminated. And in the future, the kind of evolution from that point would be about thinking about mental health data scientists having an active commitment to reducing stigma associated with mental illness and increasing public understanding of science. So I think what's important here is that, data are not just data, they come from real people. And we can see how misunderstandings about data and how data are collected can lead to significant problems. So there are huge debates going on at the moment about whether we ask for gender versus sex in surveys. There's a lot of conversation about how that's going to be represented in the census. there are also issues with, the way in which particular teams or professionals, for example, in the NHS, habitually code different kinds of information, the shorthand that they might use and what that represents. And there's also a potential influence of the timing of data collection, something I think during COVID we've become particularly alert to. But I think if you're looking historically at data going back through decades, it's important to think about the context in which those data were collected and how that might influence what people are disclosing or the experiences they're having. I think the other thing to flag is that data scientists are in a position of privilege. And so we owe a commitment to the communities that we are aiming to serve and whose information is helping us to deliver these new discoveries, which we hope will be beneficial. But that benefit can sometimes be a long time coming. So we need to think about what we can also be doing in a more immediate sense to change the way that mental illness is understood in our communities. Okay, so just drawing to a close now, I'm going to pull out a few general themes from the checklist as a whole, flag some next steps, which are basically, please use the checklist, and then we'll have our Q&A session. So the first general theme, I think, is all about kind of technological and digital innovation. A lot of our stakeholder priorities for the future require a degree of innovation in this area and new solutions to meet the problems. So new ways of dealing with facilitating remote access to data, innovation in how we de-identify data, for example, to allow more qualitative data to be used without threatening people's anonymity, and also thinking about how synthetic data can be deployed towards kind of open science goals, again, without threatening people's anonymity. And also thinking about how we can continue to improve our data security in terms of preventing leaks and breaches, but also secure linkage of data from multiple sources, which has such value for the kind of insights that we can derive. I think another big theme is the sense that data science needs oversight structures. So if I compare this to the work that I do in clinical trials, there's a really strong governance structure around clinical trials in terms of registration in public clinical trials databases, especially if you do your clinical trial associated with the clinical trials unit, which would be really expected by a lot of the major funders. You will also be having monitoring visits from a clinical trial manager, and those can continue long after the trial has finished to ensure that you're storing data long-term in an appropriate way, for example. And there are also things like good clinical practice modules that make sure that people are appropriately skilled before they embark on that kind of research. So I think we don't have quite the same robust structures in place for data science, and I think they would be a real asset in terms of producing the best quality research while taking account of the kind of ethical and community issues that apply. But there is a bit of a tension here between that need for kind of training and oversight, but also the desire to be a bit more democratic in terms of data access and open up data access perhaps to patients and participants. So I think that's something that requires a little bit of further thought and consultation. And I think a third theme is about founding what we do as data scientists in sort of profound ethical principles with appropriate robust consequences for people who violate those principles, rather than a kind of simplistic set of rules or boundaries. So I think we're looking for data scientists to have a really deep understanding of the work that they're doing, of the data collection context, and of the lived experience of the people that they're aiming to support in the long term through their science. And there is a danger here, because it is perfectly possible to do data science without any engagement with people with lived experience of the thing being studied. And I think we should be working to make sure that that happens as little as possible. So finally, I just wanted to sort of flag that I think researchers, even those engaged in really fundamental discovery science that maybe is quite far from being implemented in the community, can still play a role and make a difference in the mental health community more broadly through ongoing knowledge transfer, through science communication, and also really just responsible reporting of what you discover in your science that that works hard to not just to avoid perpetuating stigma, but to push back against the stigma that still exists around mental illness. So in terms of next steps, please download our checklist. We are very proud of it. Please read the illustrative case studies. They provide really great and exciting examples of how we can apply some of these recommendations. We hope that you will use the checklist, especially when you're writing grants, designing new studies and new research programs, or when you're thinking about work that's really focused on innovation and experimentation in data science, you know, pioneering new ways of processing data, analyzing data, and so on. We made it because we want it to be used, and we hope that you will use it. I want to particularly thank Lizzy Kirkham, who really did all of the hard work here and is complete wonder. Also, Iona Bend, Stella Chan, Catherine Crompton, Matthew Iveson, Stephen Laurie, and Andrew McIntosh, who have helped with different components of this study, and all the members of our stakeholder advisory group. So we're going to move into an opportunity for questions now. Before I introduce the panel, we would ask that you post your questions in the chat. I will chair the panel and I will pick out questions and read them out and invite our panelists to respond. If there's someone particular that you want to talk to, you can specify that in your question, but otherwise I will try and match your question to the person I think is the best recipient of it. And we will do about 20 minutes of Q&A, I think, provided that there's lots of things that you want to ask us. And then we'll wrap up for the day. So yeah, please start thinking of your questions now and typing them into the chat. While I introduced Mr. Mahmud Al-Gailani, who is a former member of Vox Scotland, a user-led mental health collective, and also a member of our stakeholder advisory group during this project. Dr. Lizzy Kirkham, who is a postdoctoral research associate in neuropsychology with a particular interest in early life stress and the consequences for mental health, and was the research lead on the checklist that I have just been talking about. And Dr. Matthew Iveson, who is a senior data scientist and a specialist in mental health data science, especially looking at how mental health or mental illness is transmitted within and between generations in families. So I will stop sharing my screen so you can see all our lovely faces. Here we are. And I will have a look in the chat and hope that we have some questions. Hang on, let me just get rid of my participants list. Wonderful presentation, so sensitive and scientific. Thank you. That's my favorite kind of question because it's just a lovely compliment. Okay, so here's our first research question. Did we find any of the recommendations that came out of the study unexpected? That's a really great question. Thank you so much. Lizzy, maybe you could have a go at that. Did you think that anything in the checklist was a surprise based on what we were expecting?
I think partly the kind of, although we tried to keep a balance with the issue of consent in terms of maximising scientific discovery and retaining control, there was quite a lot of participants were quite keen on the control side and making sure that that was kept and included in some way. Also, I think something that I hadn't thought of before that people told us about their experience was when, in terms of access to data, people were talking about occasions where, for example, there was such a convoluted process to get to some data that some of their colleagues had been trying to find ways around it, like having the same password across all the sources of data, which paradoxically meant that it was actually less secure. So that was something that we brought into the checklist about making sure that data could be accessed in a way that was still totally secure, but also accessible, so as not to prevent people trying to get around that sort of thing.
Mm-hmm. Thank you, Lizzie. Next question. So someone is interested in whether we know whether young people and children would have similar concerns about the use of their data in data science. This is a tricky question because we have not done that study yet, but I wonder if I could ask Mahmud, do you think the priorities of kind of younger people with lived experience of mental illness are quite different to adult priorities, or would you expect them to align pretty much? Maybe I need to unmute you.
Yes, thanks.
Thank you.
I'm not entirely sure. I would imagine that young people would be potentially more susceptible to being open about some of their data and sharing it more for the benefit of future patients or people with lived experience. And given I'm a father of a 16-year-old, I have her voice in my mind, where she would certainly be quite willing and interested in being involved and sharing. But I suppose it really depends on the data, on the research, on the awareness that you've been given about the research and the data and how it's going to be used. So I suspect that there would be variations. Some would and some wouldn't, but equally, Vox works specifically with 16 years old plus. So I'm not sure. Yeah, I'm not sure how the statistics would be.
And maybe I'll ask Lizzie as well on the same question, because before we did this Delphi study, you did a UK-wide survey of attitudes to data sharing. And I don't think we included under 16s, but were there any kind of age-related trends in those data?
Not really. We kind of expected that there might be an effect of age, but when we included age as a continuous variable, so we didn't split it up into groups. But when we did it that way, there wasn't evidence of a pattern, which suggested that at least in the people that took part in our survey, they were relatively similar across age groups. Although there was, when looking at it in when we separated it into categories, there was some suggestion that people of sort of my age, around entering the workforce, and maybe people who are looking for a mortgage and that sort of thing, were a bit more nervous about sharing their mental health data. So that's something that we might look into further in the future.
Yeah, that's really interesting, the way particular life stages might change your attitudes. Okay, here is a question. This is lovely. I think the checklist could be applied to all administrative data science. Do the panel feel there are parts of the checklist that are more specific to mental health data science? Matthew, I wonder if you want to have a go at that one based on your kind of broader experience of working with lots of different kinds of data.
Yeah, sure. I absolutely agree. The checklist is very applicable to a lot of different kind of disciplines of data science. In particular, the kind of commitment to bring data providers, that being the patients or non-patients that are actually involved in providing the data, with you in the research, I think is particularly important. And having in the back of your mind the implications for that population in terms of healthcare interventions that go on after this. I think that's a lesson that we all need to learn regardless of our discipline. And yeah, I think that is the drive that is happening just now, is much greater focus on engagement Yeah, I'm very happy with that personally.
Thanks, Matthew. So there's a question here about whether we have any advice on how best to engage young people as stakeholders who have lived experience of mental health difficulties, but will likely not have experience with data science. Perhaps training in data science so they can better engage with every stage of the research life cycle, as well as informing study methods, etc. I completely agree. I'm going to try and answer this one. I'm sorry, I'm going to just take chair's privilege, but I completely agree with that suggestion. And I think, yeah, we need to, instead of throwing our hands up and saying, oh, there's no one with relevant expertise who can contribute to this, you know, the science I do is very complicated. We need to get out and give people those skills if they don't have them, so that they can engage and they can inform that research. And so it's a matter of, you know, picking out what is the essential information that you need, you know, short of doing a degree or a PhD, to be able to be a valuable informant in that context. So something we've done as a team is we developed a kind of research 101 training course for autistic people. That's another big part of my research, to come in and learn more about research in order to become more informed consumers of research, but also more informed participants and kind of partners and collaborators. Yes, Mahmud, yes, please do add something to that. Oh, and do I need to unmute you again? I'm sorry, I haven't given you adequate control.
Not a problem. Yeah, that's a great suggestion. And I suppose the one thing that comes to my mind is there's a lot of third sector charities that work with young people, you know, young Scots or children in Scotland, for example, and they have their own advisory groups of young people. So there's a huge potential for partnership working and developing skills of young people as well. So it's having a kind of mutual exchange of knowledge would be really useful, really good.
Mahmud, I've made you a co-host now so that you will have the power to unmute yourself in future. I'm sorry I didn't do that before.
Thank you. I have the power now.
You can mute me next time as well. Yeah, no, completely agree. And I think, you know, working with third sector organizations who've already built relationships of trust is a really valuable way of engaging, perhaps especially with young people. Okay, someone has brilliantly, thank you very much, taken part in many data science projects. Good for you. And while they're confident on confidentiality of data, they wondered if there were any examples of breaches of security. Matthew, I don't know if you're aware of any that you're happy to talk about.
So I guess when we talk about breaches of security, we imagine like leaving a pen drive on a train or something. There's nothing like that in recent memory anyway. And it's partly because the training that researchers all go through to use this sort of data, they have to be accredited, and so they have to complete a fairly rigorous training course and sign lots of legal agreements. And we're made painfully aware of the consequences of allowing a breach to occur, both financially and future employment-wise. Probably the most frequent things are very small lapses in judgment, which tend to get caught in the disclosure process. So it can be things like generating two tables that seem separate, but when put together may accidentally identify a small group of patients. And that's why the disclosure process is there. It checks for things like that, and it combs through everything you've ever produced and makes sure that the things you're about to produce can't be used in conjunction. So nothing major now.
Good news. Thanks, Matthew. Someone is asking what's next for our team, thinking about the stakeholder panel's work going forward. Will we have any role in capturing how people get on using the checklist? That is a great question. Lizzy, I'm going to ask you if you have got any thoughts about what we could do next with the checklist.
Yes, so in the immediate future, the MRC funding body are creating a mental health data platform, and we are hoping that it's not decided who's actually going to get the funding to do it yet, but we're hoping whoever it is will be able to use our checklist to help in setting that up. So that's something that's happening quite soon. And actually that was kind of what we had in mind when we first started thinking about how to design best practice guidance. I haven't actually thought about how to capture whether people are using it and how they're finding it. We're still very early stages of kind of trying to let people know that it exists and that we would like them to use it. But that's a good idea. We'll have to have a think about how we can capture that.
Absolutely. So there's a question here that I think maybe results from me just not being very clear about something. Someone's asking, it was mentioned that participants are hesitant to report unsatisfaction in healthcare services. How can we maximize these reports? I think actually that's me not being very clear. Actually, what we found in our survey is that those people who are least satisfied with the healthcare they've received are also least likely to want to share their data. So it's not that they're reluctant to report that they weren't happy with their healthcare. It's that having received healthcare that they weren't very happy with, they're then also a bit less keen for people to access their data. And our assumption is that that reflects a kind of sort of broader distrust with the system of healthcare and research as a kind of unified body. Lizzy, is there anything else you'd add on that one?
Just that it reminded me that something that I was speaking about yesterday, which came out of our survey, was that because people with mental illness tend to be less satisfied with NHS services, and that includes physical health services. I think it's important that if you're trying to improve satisfaction, you think about what would make these people more satisfied. It's a big question. I guess a lot of it's to do with stigma and also diagnostic overshadowing, where people go along for a physical health condition and they are ignored because they've got a mental health condition, or the symptoms are put down to the mental health condition. So that is something that we're hoping to look into in future, and which might help people feel more satisfied with the healthcare they're receiving.
Absolutely. Someone's asking about where they can access the Research 101 tutorial for autistic people. I'm sorry it's not out yet. I'm going to put it out soon. You just have to watch this space. Sorry, that's a very quick response. Okay, this is a great question. Did you find it hard to engage researchers with experience in data science and lived experience of mental health conditions? Because there can still be such a stigma around disclosing lived experience within academia. Personally thinking about times I've disclosed and been told I'm too close to the data and potentially biased, wondering if this came up for people that took part. So I'm going to ask Lizzy about our recruitment process first, maybe.
Yeah, I was quite keen to answer this because actually we started off with a snowball sampling technique where we basically asked people who were interested to then ask other people who might be interested. But actually, as that was going a little bit slowly, we put it on Twitter, and I was somewhat inundated with private messages from academics with experience of mental illness, which wasn't a surprise to me, but perhaps is a surprise to some of the wider public. And so there were a lot of people that wanted to help, and I think I've just tried to make sure, as we've been publicising this checklist, to reiterate that it is designed both for rigorous scientific practice and inclusion of the views of people with mental health conditions. And so far, we haven't had anyone having an issue with that side of things. And I think hopefully our participants trusted us that we respected all of their expertise, and as far as I know, they were okay and didn't encounter that with our research, and I haven't encountered it in advertising the checklist either. So that's progress, hopefully.
Yeah. Mahmud, I wondered if you wanted to add anything on that sort of idea of bias, and that lived experience would somehow prevent someone from having a reasonable or an objective viewpoint.
Yeah, I suppose can never really underestimate the power of stigma, but also particularly the fear of not knowing how people will react around you. Certainly my experience as a participant and as someone who's been involved in many studies in the past as a person with lived experience, my experience of the study was excellent. There was lots of opportunities for people to potentially challenge if there was a need to challenge other views, and there was a lot of openness around and sharing that openness, which obviously gives you trust that actually you're in a safe space, you're in a safe environment, and you can talk about these issues. So my experience was definitely very positive of the study, but I do appreciate it can be very challenging, particularly if you're not close to your colleagues or if you're not aware of their kind of notions or ideas around mental health, and that might be difficult.
Mm-hmm. Thank you, Mahmud. I think we should draw to an end there. There have been some additional compliments and useful links posted in the chat. Thank you all. But we seem to have exhausted the questions, and I think it is just a lovely thing to finish on time on a Friday afternoon. So that seems like a really good thing to do. Thank you so much, Lizzy and Mahmud and Matthew, for joining me to help answer questions. I was really glad to have your expertise here. I would have been floundering with some of those. Thank you all who came to listen to this. Please do spread the word about the checklist. We just really want it to be useful. We made it for a reason. It's out there, and we would love to see it deployed in your research, and let us know if you do, because we'd be really delighted to hear about that. Thanks very much. Bye, everyone.
Bye-bye.